our session by Professor Gyula Gal, Professor of Intervention Neuroradiology, Odense University, Denmark. Professor Gyula will discuss midterm experience with the KAARS devices, the extent and the contour.
Thank you, Chairman. Thank you very much for the invitation and welcome everyone to the meeting. I will talk about, in this lecture, about two new devices. The first one is a contour, which is, let's see how I can push this. This is an intrasaccular flow diverter. It is a braided double-layer nitinol disc. We place it inside the aneurysm at the neck, and it will divert the flow from the sac to the parent artery. It is very, very tight. It is 144 wires. A usual flow diverter consists of up to 90, the most, but much, there are also 48. So this is a very tight device. It can be deployed through an O21 up to O27 microcatheter, depending on the size. It is retrievable and electrically detachable. The current sizes now is between 5, 7, 9, 11, and 14 millimeter. The company is working on bigger ones, up to 20 millimeter. The biggest one, 14 millimeter, is suitable for aneurysms up to 10.5 millimeter in diameter. And this is how it looks like. You can see here, this is the assembly point, and around this point the mesh is very, very tight, and out to the periphery it gets less tight, but it's still very strong flow diverter effect. So let's hope this video will work, because it will show you how to work with the device. So it comes through the microcatheter, and we push it out carefully, pulling back the microcatheter, and when it is out, it will get this shape. And what I want to show you is that it is stable. If you look at this part, when you push like the blood, it will not move inside the aneurysm if the size is correct. So this is a very nice demonstration of how it works. And again, once it is a double-layer device, and this is the diameter that counts. So it's not the neck. The neck is not so important for us, but this diameter, up to 10.5 right now, what we can cover. So I will show you a couple of cases to demonstrate how it works. 64-year-old female, she had a big basilar tip aneurysm and the right MCA aneurysm. And we started with the basilar tip, and you can see the sizes here. So the neck was quite wide, the aneurysm was big. It was on the edge of what we could do at that time, and the company was hesitating, but I said, let's try to check if the device can work. And this is the device, 11 millimeter. This was the largest at that time, inside the aneurysm. This is what you see here already. There is some flow diversion in the frontal part of the sac, and I waited 25 minutes because I was not sure if it was stable enough. After 25 minutes I detached, and then I went on and treated the other MCA aneurysm, which is very, very difficult because it has no neck. It looks like a tent, and it was very difficult to get the device in a stable position. So this is the working projection, microcatheter, and the device. What you see here, the most visible point is the assembly point here. This is the angio. You see how much of the device is outside. So everything is outside of the aneurysm, actually, to get covering of the neck. So I waited 40 minutes before detachment. What you see here, there was significant slow flow in these small bulging daughter aneurysms. So this was a good sign. This is the final angiogram, and then I tell you a couple of words about this patient. I wanted to stop the double antiplatelet therapy after 6 weeks, which was a mistake. I didn't know that. I wanted to test if it works, because company said we don't need to do it. The patient developed ischemic stroke 8 weeks after the treatment, and she had to be taken to the hospital, and it resolved on RTPA IV treatment. And then I restarted the platelet inhibition and continued until 6 months. This is to explain what we see here, because it's 7 months, the patient is still on double platelet inhibition, and the aneurysm is still there. But what you see is that the flow in the aneurysm is very slow and it is stagnating. So I said, okay, let's wait. This is the lateral view, same stagnation in the sac. At 7 months, the MCA aneurysm is much smaller. All the small daughter sacs are gone. And the follow-up at 18 months shows almost the whole aneurysm is completely occluded. There is a very small remnant at the base in the basilar aneurysm, and the MCA aneurysm is also almost fully gone. So this is a good result. Now I show you how it should work in the best scenario. This is an ACOM aneurysm with a wide neck. This is a view from behind. You see it's incorporating the orifice of the left, the right A2. So the neck is very wide. And here I choose first to place a big device, the Contour 11, which was, it was in the beginning of my experience, it was probably too big. So I decided to replace it and put a 9mm device that was better. It had better suitable for the aneurysm. And also here I waited 10 minutes, and when I did the angiogram, this is what I saw. So the whole aneurysm was blocked, and also the flow in the right A2 was blocked. So I didn't dare to detach this. I had to puncture the other groin and do an angiogram on the right carotid. And when it showed good flow in the right A1 and A2, I detached the device. This is after the detachment. This is the angiogram, and this is the final angiogram. So she recovered. There was no signs of ischemia. This is a follow-up at 6 months. You see the flow is back in the right A2, and this is the situation before the treatment. So the whole aneurysm is completely occluded, beautiful case. This is how it should work in the best scenarios. Okay, so I summary, because I have to run. The device is very easy to deliver, deploy, and detach. It is thrombogenic, so we have to give platelet inhibition, double platelet inhibition, like for stenting on flow diverter, if we don't want to have post-procedural complications. I think the follow-up should be done later, not 6 months, because it's too early, but we had to do it because we were in the study. So the results immediately good, and also the follow-ups are excellent. We didn't have any peri-procedural complications, the one that I mentioned, and there was another small TIA, and in my opinion, this device is very efficient. I used it in many other cases that I cannot show you. Learning curve is not very long. It's easy to learn, and this is very helpful for difficult aneurysms that are difficult to treat with other tools. I don't treat easy aneurysms with this one. So this was the first part of my talk, and I would like to have the next presentation, please, if you put under the code next end. Thank you. Thank you. Wonderful. So I will show you the other device, which is a brother or a sister of this one. If you look at what's the difference, it is also a 19 mesh disc. We put it inside the aneurysm, but we use it together with coils. Why? I will tell you. It is much significantly less number of wires. The sizes are a little bit bigger, and these are for aneurysms that cannot be treated with Contour because the aneurysms is wider, but it can be placed at the neck, and it helps to achieve very good packing density. So the smaller ones can be delivered on the 21 microcatheter. The 1114 needs the bigger microcatheter, and then another microcatheter can either go through this device or around to place the coils inside the aneurysm. It is retrievable, repositionable, and electrically detachable as the contour. So I show you how it works. This is the device, so you can go through the device, but nowadays I always put the microcatheter first. So I jail the microcatheter because it's much easier to work with that, and then deliver the coil, and this mesh at the neck will help the coil to stay inside the aneurysm and achieve good packing density. My very first case was this basilar tip aneurysm. You see the neck is 9 millimeter, incorporating both orifices of the PCAs. Technically very easy to get there, place the device, and at that point I put the microcatheter after I place the device, which I don't do now, but this is how it works. This is the wire, and then fill the whole thing with coils. The device will keep the coils there. This is the final angiogram. This is the follow-up at 5 months. What you see is that the right PCA is not filling. So is it a problem? It's not a problem. This is a very good sign because it comes from the carotid. So the whole aneurysm was remodeling due to the treatment, and this is the best sign that it will never recover. I have 5 years follow-up on this patient. It is still fully occluded. I show you the big ACOM that is not very wide neck, but this is a difficult to treat aneurysm because of the size and because of this portion is difficult to pack. So what I do here, I place the big catheter and the smaller one in advance, so that through the big one I put the device and then I pull back. So you see the device here is just 7 millimeter just to cover the neck, and it can be pulled back exactly to the right position at the neck here, and then fill the device with the fill the aneurysm with coils. What I want to show here, this device has also flow diverter effect. So even without coils, the flow is slowed down. So it works together, and then push the coils, and this is after the embolization. All the branches are open. This is the final angiogram. Follow up 8 months. The aneurysm is completely occluded, and you see all the 3 branches are open. So this is another one. Very wide neck, MCA aneurysm. The neck is very wide in all directions. Difficult to use, probably with 2 stents, but also there is still difficult to treat. But this device with the 2 catheters, I just put 2 coils, and this is the final angiogram. This is the follow-up at 7 months, and you see the aneurysm is completely occluded. All the branches are open. Last one, very large basilar tip aneurysm. It wouldn't be able to place the contour because the diameter was too big. Placing the 2 catheters is very easy. Put the device, the flow diverter effect is there, and then fill the aneurysm with coils, very easy. Final angiogram, follow-up 7 months, complete occlusion. I took this to demonstrate that there is no flow in the aneurysm, it's just the left one. So, summary. This device is also very easy to handle. No complications except 1 TIA. It was my fault. Good immediate angiographic results, and all follow-ups at 6-8 months showed excellent results. Many of them progressive thrombosis after SEC. Thank you very much. Sorry, I pushed the... I will give you the time back on my next presentation. Thank you very much.
Thank you, Dr. Gyula, for very nice presentation.